Good afternoon, everyone, or good morning to you, if depending on where you are in the country. Thank you for joining us today. This is the second webinar on a webinar series on Diabetes 101 for behavioral health specialists, partners in health, the role of behavioral health providers in diabetes prevention and management. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. Just a little bit, some information about the National Center and just a brief introduction. I've been with the National Center for Health in Public Housing for 10 years. I am responsible for providing training and technical assistance to community health centers with emphasis on those health centers located in or immediately accessible to public housing. However, the training and the resources provided by the National Center go to all health centers across the nation. And as you know, all the priorities, not only the HHS priority, but the HRSA priorities affect all special and vulnerable populations. So when we discuss diabetes or cardiovascular diseases or smoking cessation or any of the other chronic medical conditions, we're talking about conditions affecting people experiencing homelessness, those living in public housing, migrant or agricultural workers, those who are part of the LGBTQIA+ community, etc. Some housekeeping items right now. All participants are muted. If you have any questions or if you have any comments, at the bottom of your screen, you see the chat box and you can type your question. Also, if you would like to ask a question verbally or you have any comments, please, and you would like to make your comment, please use the raise hand icon as well, and your line will be unmuted. This webinar is being recorded, and the slides, recording, and all the resources will be sent to all participants via email in the next few days. So before we get started, we have a poll question, and which best describes your type of organization? Fide?
Okay, thank you, everyone. And thanks to everybody who's joining us today. So far, we have 58% of health centers, 17% from nonprofit organizations, 8% from local or state health department, and 8% from PCAs, and another 8% from NTAPs.
Thank you, everyone, for your responses. So we're going to move on, and just a quick description of the National Center for Health in Public Housing. The National Center for Health in Public Housing provides training and technical assistance to community health centers, as I mentioned. We have three main divisions: the Training and Technical Assistance Division, the Research and Evaluation Division, and the Outreach and Collaboration Division. We work very closely with the U.S. Department of Housing and Urban Development to make sure that we are addressing the healthcare needs of those living in public housing. And the National Center is funded by HRSA to provide training and technical assistance to all health centers across the nation. According to 2021 UDS data, in 2021, health centers provided services to 30 million patients. 458 of the health centers reported to be located in or immediately accessible to public housing, and they provided services to over 5.7 million patients. 108 of all community health centers are public housing primary care grantees, which means they receive funds from HRSA to provide services to this population. In the same year, they provided services to over 900,000 patients. On your right side, you can see some of the resources that we've done. And this map in particular is showing the locations of the 108 public housing primary care grantees and the public housing agencies located in or immediately accessible to these health centers, as well as the public housing developments. You can find this resource on our website, www.nchph.org. A little bit of the public housing demographics. According to HUD, and this is the most recent data, this is 2022 data, there are around 1.5 million residents living in public housing. It's really important to mention that 38% of the public housing households are reported to have at least one person with a disability. In regards to race and ethnicity, 52% are white, 43% are African American, and 26 are Latino or Hispanic. Another issue that I would like to highlight is that 19% of the households also reported to have at least one person who is over the age of 62. Same with children. 36% of households reported to have a children younger than 18, and 32% of these households are female-headed, and they have at least one child. There is a publication that was produced by HUD and the Center for Disease Control and Prevention, National Center for Health Statistics, showing the health status of those HUD-assisted adults. This publication now is being reviewed and is going to have the most recent data. The one that is currently available is from 2006 to 2012. And most, if not all, the information was taken from the National National Health Information Survey, and there is some information from NHANES as well. When we analyze the numbers for this particular webinar, we see that 18.6% of those HUD-assisted adults have diabetes, and is almost the double of people when you compare them to low-income renters who are not HUD-assisted, or all adults in the United States. There another issue that is very closely related to diabetes is the overweight and obese population in public housing and those HUD-assisted adults. And 71% of those HUD-assisted adults reported to be either overweight or obese. Another priority for HUD is smoking. There was an initiative and this initiative was to stop the use of tobacco in public housing. And the same document shows that those living in public housing, or one person out of three living in public housing, are current smokers. And if you see the other HUD programs like the Housing Choice Voucher or the multifamily program, the numbers are about the same. And it's almost 10% to 12% higher when you compare them to the US population. So this for this session, we are going to briefly review the role of behavioral health providers in diabetes prevention and management. During the first session, we went over the concepts of prediabetes and diabetes. We also discussed briefly some of the resources, some of the risk factors, as well as some of the potential initiatives in public housing and other health centers, and the resources that organizations like the Centers for Disease Control or the American Diabetes Association have on their website. for behavioral health specialists treating patients with diabetes or people with diabetes. So today we are going to focus on a couple of areas. We are going to identify how mental health professionals can help patients with diabetes. We are going to compare depression and diabetes distress. We are going to recall successful interventions that can be used for people with diabetes and depression, and identify common worries a patient with diabetes experience. In the United States, almost 18% of the population is affected by a mental illness. This is very important to mention because if we are talking about diabetes, we are going to have the issue and the dilemma about the chicken and the egg. Was the patient or a patient who was diagnosed with diabetes, and you're seeing this patient for the first time and is experiencing any mental health disorder, whether the patient had this disorder before the diabetes diagnosis or after the diabetes diagnosis. And this is really important because there are several ways that we can analyze this. The history is extremely important, but at the same time, the DSM-5 also mentions anxiety disorders and depression disorder due to chronic medical conditions. So we need to make sure, and we need to have our discussion with our patients and see whether or not the mental health issue affected to our patient was either before diabetes or after the person was diagnosed with diabetes. In regards to the mental health issues affecting those with diabetes, we have that people who have been diagnosed with diabetes are more likely to be affected or to have depression. And 18 to 45% of people with diabetes exhibit diabetes distress, which is a condition where the emotional burden and stresses of living with diabetes manifest in physical ways such as fatigue, tension, and burnout. And adults with diabetes have been found to have elevated rates of anxiety symptoms as well. In regards to diabetes distress, even though we are going to discuss later the issue of diabetes distress, we need to remember that diabetes is a chronic medical condition. Many of our patients are affected by some social determinants of health. So when we are trying to talk to our patients who are newly diagnosed with diabetes, the issue will be access to healthy food, whether or not they have a stable housing, whether or not they have insurance. All these issues are going to affect the mental health of those patients who are newly diagnosed with diabetes. When we discuss diabetes, we tend to, as we said during our first session, we tend to think about the adult population. However, we need to have in mind that diabetes can also affect the teenagers and children, and this particular population is also affected by some mental health conditions. The recent data shows that 27% of the teenagers with type 1 diabetes have or are at high risk for depression. And youth with type 2 diabetes are also at risk of depression, with rates ranging from 8% to 22%, according to CDC. Also, people with diabetes tend to have eating disorders or eating issues, specifically women. 51.8%, almost 52% of women with type 1 diabetes have an eating disorder, and it's about the same issue when you see patients with type 2 diabetes, and we're talking about bulimia or binge eating or anorexia. And remember, there will be some issues with this and the use of insulin in some patients. Some patients tend to either decrease the amount of insulin or increase the amount of insulin depending on the eating disorder, just to make sure that they are keeping up with their weight, or if they are obese, or if they want to lose weight. So these are issues that if as a family practitioner or any doctor or nurse seeing a patient, that this patient need to be referred to a behavioral health specialist as well. The American Diabetes Association has a publication, the Diabetes Standards of Care, and they mentioned the psychosocial issues and some of the recommendations for these patients. And the first recommendation is that psychosocial care should be integrated with a collaborative patient-centered approach and provide to all people with diabetes. This is extremely important to work. This is a team-based approach. If someone is diagnosed with diabetes, or the person is in a follow-up visit, or if the patient has any complication, the patient needs to be evaluated by a behavioral health specialist to make sure that this person doesn't have either depression or anxiety or any of the eating disorders that we mentioned. The psychosocial screening includes what the patients think about their condition, the expectations for medical management, the mood of the patients, and the resources that they have. We just mentioned the social determinants of health, anything that is financial or social or emotional, and the psychiatric history of the patient. I was just mentioning that if you have a patient with diabetes and the patient has depression or a panic attack or any anxiety disorder, we need to just make sure that we find out whether any of these conditions were either before or after the patient was diagnosed with diabetes. Also, the other recommendation is that providers should consider assessment for symptoms of diabetes distress, depression, anxiety disorder, disordered eating, and cognitive capacities. This is also really important, especially if you are, if you have seniors, any cognitive issue needs to be evaluated, just to make sure that the patient is able to follow out any of the recommendations or any of the guidelines provided by the clinicians. And same for the last recommendation, that all patients over the age of 65 with diabetes needs to be evaluated for any cognitive impairment and depression. So I'm going to stop for a moment. We have a poll question, and the question is your health center or your organization assessing the psychological status of your patients with diabetes? True or false? Fide? Excellent. Go ahead, Fide.
No, yeah, thank you, everyone. So far, pretty much all of respondents are saying true, that they are currently assessing psychological status among their patients with diabetes.
Thank you, everyone, and I would like to congratulate everyone. That is great news that all patients with diabetes are being referred to a behavioral health specialist to assess any needs that the patient have in regards to the mental health status of these patients. And the last poll question that we have is, what percentage of your patients with diabetes have a psychosocial issue? Fide?
Okay, so 44% stated 31% or more, 33% said 21%, and 30%, 22% also mentioned between 11 and 20%. And those are the final results.
Thank you, Fide. This is really interesting. The national number or the percentage is that 20 to 30% of those with diabetes experience a psychosocial issue. Since we are dealing with low-income populations or underserved populations that are affected by the social determinants of health that we mentioned, we see that in health, community health center settings, the percentage is even higher than the average number provided by the federal organizations. So I can see that 44% of those attending this webinar are referring that 31% or more of their patients with diabetes have a psychosocial issue. Thank you so much for sharing that. So we have a patient with diabetes, and there are several opportunities to assess the psychosocial status of the patient. At the diagnosis, when the patient is first seen by the provider and the patient is diagnosed with diabetes, this is a really good time to assess for any of the conditions that we mentioned, either anxiety, depression, or see whether or not this patient has a cognitive issue. When the patient has a follow-up, is another good time to see whether the patient has been experiencing anything that is complicating how the patient is being treated. We mentioned insulin, for instance, whether or not the patient is able to understand how to inject the insulin, whether or not the patient is able to get insulin if the patient is on insulin. Remember that one of the biggest issues and concerns are that all these medications are expensive, and some patients may not have fully access to these medications. The other thing that is extremely important to mention, at least in public housing, is we can recommend patients to exercise daily, or we can recommend our patients to eat healthy. But because in public housing, there is a high percentage of those living in public housing who are under the poverty line, they may not have access to healthy food, or they may not have access to a safe place where they can exercise. And these patients may experience some behavioral health issues due to these social determinants of health. If the patient is hospitalized, even though we are in primary care settings, but when the patient is hospitalized, it's another good opportunity to assess the psychosocial status of our patients. If the patient has any complication, that's another good opportunity to assess or reassess whether there is a psychosocial issue, like patients who are, we go back to our training last week, we discussed neuropathies or issues that has to do with diabetes complications. Remember that some patients can be amputated due to due to diabetes, and in fact, the first reason why people get an amputation in the United States is diabetes. So these are really, really serious complications that are going to affect the psychosocial status of our patients, and we need to make sure that we are providing the referrals to specialists, behavioral health specialists, when we are seeing our patients, and one of our patients has any of the complications, again, in amputations or kidney failure, or well, the patient can get blind due to diabetes. We need to make sure, and unfortunately, these are complications that can be prevented, but this is the reality of the condition. Some patients are good patients when it comes to diabetes. Some others are more difficult to deal or to treat. And we need to make sure that we are providing the mental health assessment of our patients. If the patient has some problems achieving the A1C goals, again, most, if not all, health centers have SDOH screening as part of the electronic, the EHRs. So this is extremely important, just to make sure that there is an evaluation of our patients, not only from the medical perspective and the behavioral perspective, but also the social perspective. And if there is any issue, our patient needs to be seen by one of our case managers. There are some situations or conditions that warrant referral of a person with diabetes to a mental health provider for evaluation and treatment. You see a list here, but there are a couple of things that are, in my opinion, are really important. And if the patient has issues with their condition, even though the patient has received diabetes education, and we also mentioned the diabetes self-management program, the diabetes prevention program, we need to make sure that the mental health status of the patient is assessed, or if the patient has a screening tool, and the screening tool shows some depressive symptoms, so the patient is likely to have depression, or if the patient is diagnosed with depression, that this is a really good opportunity for the provider to refer the patient to a behavioral health specialist. I was mentioning the intentional omission of insulin or oral medication to cause weight loss. This is something that we have seen in the general practice. Patients who are auto-regulating their insulin if they are overweight, and they tend to inject or add more insulin. So what they are doing is that there is the risk of hypoglycemia, but at the same time, the patients are urinating more, and what they are doing is basically losing fluids, and that's the reason why they are losing weight. But this is something that it needs to be evaluated seriously. Or when the patient has a mental illness, I just mentioned that sometimes patients have been diagnosed with depression even before they were diagnosed with diabetes. So we need to make sure that we are addressing all these, and it's really important the history and how we discuss the issues with the patients. We need to take some time, discuss what diabetes is, what the complications are, what the treatment recommendations are, and if we see anything that we think it will need that this patient is assessed for any of the disorders, mental health disorders, we need to refer this patient to a mental health provider. A little bit of diabetes distress. According to the American Diabetes Association, diabetes distress refers to significant negative psychological reaction related to emotional burdens and worries, specific to an individual's experience in having to manage a severe, complicated, and demanding chronic disease such as diabetes. One of the main concern of our patients is it's very difficult to deal with some medications, the dosing, the frequency, the titration, the monitoring of blood. That is stressful for our patients. So we need to make sure that when we have a conversation with our patient, we need to make sure that there is no any distress, or this condition is not providing any distress to our patients. So we need to, again, monitor our patients, and then specifically if the treatment targets are not met, or if the patient has any diabetes complication. These slides are going to be sent to all participants, but there is a questionnaire. This is the diabetes distress scale. You can also find it on the American Diabetes Association website. This is a 17-question scale where you can find whether or not the condition is affecting our patients, and is there is some kind of diabetes distress in our patients due to diabetes. The next concept is diabetes and anxiety disorders. Here we can discuss generalized anxiety disorders or panic attacks that are related to diabetes. I was mentioning that the DSM-5, at least that's the one that I have access to, mentions that there are some anxiety disorders due to chronic conditions. And there is a lot in regards to how to categorize this condition on diabetes or any other chronic medical conditions being the cause of anxiety in our patients. The recommendation from the American Diabetes Association is we need to screen for anxiety in patients with diabetes complication, if the patient is receiving insulin, or if the patient has any fear of hypoglycemia, or and if the patient has, again, any of the is being affected by any of the social determinants of health, that most of them, if not all of them, being serviced by health centers, are affected by any one or more social determinants of health. I am sure that you are familiar with the GAD-7 screening tool for GAD, or the 2 screening tool for GAD. Just to make sure I brought this up, this is from the American Academy of Family Practitioners, and they have the resource, and the topic for this one in particular was anxiety due to diabetes. We can also discuss a little bit of diabetes and depression. There are some recommendations, again, from the American Diabetes Association. Providers should consider annual screening for the patient for depression for patients with diabetes, the beginning and diagnosis of complications, and when there are significant changes in medical status. Again, that is another good opportunity to assess whether or not the patient has any depression. The last recommendation is that any referrals for treatment of depression should be made to mental health providers with experience using cognitive behavioral therapy, interpersonal therapy, or other evidence-based treatment approaches in conjunction with collaborative care with the patient's diabetes treatment team. There are some risk factors for depression in general. for those patients who are diagnosed with depression, even before the patients have been diagnosed with diabetes. So we need to make sure that we have a really good history, psychiatric history from our patients, and assess whether or not the patient has anxiety, depression, if there is any adverse life event affecting our patients. So it is extremely, extremely important always to look for risk factors for depression in people with diabetes. The last one that is associated with diabetes, as we mentioned, sometimes we have some eating disorders. Specifically, we mentioned that the patient can have insulin omission, or the patient can start eating a lot, depending on what the issue, the mental health issue of our patient is. But providers should consider reevaluating the regimen of people with diabetes. Any eating disorder or disruptive pattern should be referred to a behavioral health specialist, and we need to consider screening for disorder or disruptive eating using validated screening measures as well. There are other conditions that we need to keep in mind. I mentioned cognitive impairment, but there are some patients with schizophrenia who are patients with diabetes, and in fact, some studies have shown that people with schizophrenia are more likely to being diagnosed with diabetes. In regards to treatment, we can mention, the medications to treat either anxiety or depression, the SSRIs or the SNRIs. But at the same time, we need to discuss patient daily self-care. Patient needs to get enough sleep, whether or not the patient is using any other recreational drug like alcohol or any other drugs. These are considered to somehow cause some depression in our patients. We need to promote exercise. Anything that is like yoga, relaxation, meditation, mindfulness, and show the patient or teach our patients to make positive choices. We've been discussing in another learning collaborative that we have how we can teach our patients to make healthy choices, specifically when it comes to choosing healthy foods. And that is something that is the responsibility of the entire team. Anyone who is being with a patient with diabetes need to make sure that we address all these treatment guidelines somehow. I mean, we are not talking only about the medications, but everything that is related to how the patient can improve their mood and avoid diabetes complications. Now, in regards to living with diabetes, and this is a really interesting slide showing what we need to do depending on what the patient is going through. If the patient is just diagnosed with diabetes, for instance, there would be some adjustment reactions. We know that the patient is going to have some fear or distress or anger, and these are adjustment disorders that we need to make sure that we are addressing. If a patient doesn't have any of these disorders, but the patient has history, or the patient has been diagnosed in the past, we need to make sure that we assess any anxiety disorder or psychotic disorder, any intellectual disability. So these are, this is a really nice slide showing what the patient can is going through depending on where or at what stage of the diabetes natural history is. So how can we help a patient with diabetes? First, we need to educate ourselves, and we need to learn about diabetes in general. What diabetes is, again, pre-diabetes, who is at risk, what are the risk factors, what can be modified, what cannot be modified, learn about the eating behavior or eating habit of our patients. Then we need to make sure that we understand the treatment plan of our patient, what the patient is receiving, what type of medication, either if it's oral or if the patient is on insulin, whether or not the patient is taking other medications. That is extremely important, and that's how we can help our patients. If we have that information, we can reinforce how patients can deal with diabetes. There are several ways also to educate our patients. We can have either printed or digital resources. The American Diabetes Association, if you go to their website and go to resources, they have resources for patients that professionals can use, as well as some training for behavioral health specialists. I've seen some webinar for behavioral health specialists. I've seen some training modules for professionals. If you would like to learn more about diabetes and how you can help your patient, those are really good resources. But for patients, we also have printed and digital resources. The Centers for Disease Control has some resources as well. NIDDK, the National Institute of Diabetes, Digestive and Kidney Diseases, have really good resources for patients. We need to reinforce education regarding other recreational drugs and coach our patients on how to address the psychosocial issues related to living with diabetes. If we help our patients with all these and show relaxation techniques, and if the patient is on, again, any medication such as the SSRI or SNRIs, we need to make sure that the patient understand the use, even though they are safe, we need to make sure that the patient understand how to take these medications, and we are trying to avoid polypharmacy as well. The patient has enough issues with all the medication that patient may be taking for diabetes, and we are adding additional medication. So we need to have a really good understanding for patients, and make sure that we individualize the treatment of our patients, because not all patients are equal and not all patients are on the same medications. The key messages is that people with diabetes need and want supportive health professional whom they can discuss any aspect of living with diabetes. We need to be empathic, have a communication style is extremely important. We need to have cultural humility and health literacy. Some of our patients, if we discuss with them, there will be some health literacy issues as well. Let's make sure that we speak with them in a manner that the patient understands what you're saying. In regards to the practice points, we need to meet the person, and this refers to individualized treatment, right? Not all patients are equal, not all patients are having the same conditions, not all patients are under the same stressors. So we need to make sure that we meet and know and get familiar with our patients. Also, active listening is extremely useful. Patients need to talk to someone about the condition, their fears, or any complications that they have. So to be a good listener is also a good practice if you're dealing with a patient and any psychosocial issue affecting our patients. And we need to listen to our patients. We have been doing a lot of training as well on motivational interviewing, trying to find what the patient can do to change their behavior. It's not that we are going to impose, and this is what you have to do, but let them, we need to help them find any solution to the problems when it comes to diabetes management. These are some of the other webinars that we have, and I'm going to stop for a moment to see if there is any question from the audience. I need to please just remind you to complete the post-evaluation survey. After this webinar, there is a very brief evaluation survey. So if you can have 1 minute to complete the survey, that is very helpful for the National Center for Health and Public Housing. Also, please visit our website. You will find more information about upcoming webinars, publications, interactive maps, training manuals, and priorities and conditions affecting those living in public housing. This is our contact information. If you have any additional questions, you please feel free to contact any of our staff members. And I'm going to stop again for a moment and see whether there is any questions. Any questions, Fide?
Not at the moment, Dr. No.
All right. So again, I would like to thank everyone for attending this webinar. Thank you for everything that you're doing for the patients. I've seen that 100% of your patients are being your patient with diabetes are being referred to a behavioral health specialist, and I see that 20 to 30 over 30% of your patients with diabetes have a psychosocial issue. So please keep working, and thank you so much for what you do for your patients, and have a great afternoon.